Tēnā koutou katoa, ko te wehe te atua, me whakakororia tōna ingoa I ngā wā katoa. E mihi ana ahau, e te mātua nui I te rangi, nana nei nā mei katoa. Ko mangawhau te maunga, ko whanganui te awa, ko tamaki makaurau te iwi, ko Alexandra Patrick Mutu tōku ingoa. Ngā mihi nui ki a koutou. On behalf of the Congress Committee, I extend warm greetings to everyone here and acknowledge our Creator. My name is Alexandra Mutu and I am an occupational physician. I welcome you to the closing plenary of the RACP Congress 2019, Physician, Heal Thyself, where we ask you to stop and consider how well are you looking after yourself and what are the challenges you are currently facing. This closing plenary explores how physicians impact their own health and well-being along their life course, from training through to retirement, including key career transitions, and from health to illness and back to wellness. We want to acknowledge that although we are physicians, we are humans first and foremost. Much like our children's school teachers, we do go on existing when we're not at work. Life happens to us as much as it does to the people we serve throughout our careers. Your health and well-being is important primarily for you, but also for your colleagues, your patients, the medical profession, society as a whole, and your whānau, your families. I trust that you will identify with the speakers, because whatever you're facing, you aren't alone. And I hope that you will find your own hope, resources, and strategies that will help you living your best life. We've just heard from Dr. Matt Beaumont. Thanks. As he said, Matt was a medical student at Otago Medical School, spending time in Dunedin, Wellington, and Hastings, and chose the Hawke's Bay for his first year House Officer year. He's completing his general registration year and considering future career options, plus enjoying Hawke's Bay region. And we thank him for his insights and his vulnerability and honesty today. We're now incredibly fortunate to hear from an internationally recognised expert in physician wellness, Dr. Tait Shanafelt. On a personal note, Tait's wife Jackie contributed to my well-being when my husband and I were working at the Mayo Clinic in Rochester, Minnesota. We arrived with 1 and 2-year-old sons for my husband's 2-year fellowship in transplantation surgery. 15 to 20 special interest groups were advertised to incoming fellows at a welcome dinner, and I joined side by side and met weekly with over 150 wives and over 300 children of Mayo doctors, including Jackie Shanafelt. This group of women were a great support to me as our young family settled into a foreign country with no friends or family, and we balanced the pressures of my research and my husband's completely crazy work schedule. When our third son was born prematurely in our time there, Jackie was one of the friends who brought me meals and loaned me baby gear. Perhaps groups like this are something that we should replicate here to support physician health and well-being, particularly for the families of international fellows and trainees who are often socially isolated. Among other things, while at Mayo Clinic, Tait undertook the first US-wide research on physician wellness. He is a hematologist-oncologist and is the inaugural Chief Wellness Officer at Stanford Medicine. His address on video is followed by 3 regional experts, Professor Anthony Scott outlining the Australian data gathered by what is known as the MABEL study, Dr. Margaret Kay discussing potential pathways to care, and Dr. Beth Ann Richards on designing wellbeing solutions at an individual and systemic level.
Greetings from Stanford. Let me begin by saying that our thoughts and prayers are with the victims, families, and people of New Zealand after the tragic events of March 15th. I know that many of you were on the front line caring for those victims. Please know that we stand with you in this challenging time. Today, I want to congratulate you on participating in this meeting. It's fantastic that you are engaging in this important topic. Occupational distress in physicians, including professional burnout, fatigue, problems with work-life integration, and erosion of meaning in work, are important issues. Recent studies suggest that up to half of the physicians in New Zealand are experiencing at least one symptom of professional burnout. We see a similar prevalence in the U.S., and also have shown that U.S. physicians are markedly more likely to experience burnout than workers in other fields, even after adjusting for hours worked per week and other variables. The consequences of this professional distress in physicians are substantial. They include personal consequences, such as broken relationships, problematic alcohol use, depression, and even suicide. There are also consequences for our patients, with extensive literature demonstrating a relationship to quality of care, as well as patient satisfaction. The causes of this challenge are complex. They include clerical burden, inefficiencies in our practice environment, technology that often interferes with the human-human interaction at the heart of our work, and structural problems with the healthcare delivery system that make it difficult to provide patients the care they need. We often organize the contributing factors into 7 driver dimensions. These include workload, inefficiency, loss of flexibility and control, problems with work-life integration, erosion of meaning in work, isolation and a loss of connection to colleagues, and values misalignment between the altruistic values of our healthcare professions and oftentimes the business priorities and values of the organizations in which we work. We often look at this complex issue and feel that it's an intractable problem. I want to tell you today, this is not an intractable problem. We know from 2 systematic reviews and meta-analyses that interventions work. But making progress will take all of us working together: governing bodies, organizations, healthcare administrators, clinical leaders, and individual physicians. I wish you the best for a successful meeting and Godspeed in your efforts to promote physician well-being.
It's a big problem. In one sense, it's always been a big problem. Reporting of this problem is increasing over time because of general awareness about these issues. We really need to capitalize on that in order to actually find out what to do about it through careful research. So a lot of the factors that drive doctors' mental health and general health status, we need to collect more data on, and we are doing that. We are starting to measure and label mental health, bullying, and what role those factors play in driving mental health. And this is the first kind of national longitudinal survey to do this, so we can monitor changes over time, find out what factors are changing over time that influences doctors' changes in health. In terms of doctors being at high risk, there's not a lot of data around that. We know that in terms of medical complaints, at least, that it's older and male doctors who are most at risk. But these predictive models of the risk of having poor mental health are very undeveloped in this area. So we need to do much more research on that to find out really what factors are driving this. And then only until then can we work out what to do about it.
The problem is that because all of us are actually the owners of physician health, it actually means that no one has actually taken ownership of the issues to correct it. And we've been able to work in extremely unsafe working environments that magnify our burnout. We've been able to have very poor education around physician health issues that's enabled us to just ignore it because it wasn't part of the curriculum. And it's also meant that people in leadership roles have really not articulated anything around doctors' health except knowing that they don't want to work with really impaired doctors because they have to be reported. So we actually have this really odd association with how we manage burnout, how we manage anything to do with wellness in our workplace. And we forget to check whether or not there's actually a fridge and a microwave so people can actually have lunch, whether or not there's actually after-hours healthy food available for people who are actually working 24/7. And we need to actually ensure that each of us know how to connect with each other. I think the first and perhaps the most important thing is that we have to start connecting around this issue right now. So as individuals, when we walk into work tomorrow, we need to actually make sure that we say hello, to the people who we care about, who we're actually working with, and we actually connect with them. And we recognise whether or not they're struggling, even if it's just to give them a pat on the shoulder and a smile. We don't actually have to fix their problems, we just have to ensure they have a pathway to care. We need to know our own pathway to care so that we can enter that pathway to care whenever we need to, and we need to have it as a well-trodden pathway to care so that we actually have walked that pathway, we haven't just imagined it in our head. And that's one of the problems with doctors. We know who we might see if one day we get sick, but we're never really sick enough. Reality is we need to know what that pathway really entails, otherwise there's a lot of rocks to stumble over. So the pathway to care is a really important thing, and the connectedness to enable others to that pathway of care is actually essential. We can do that tomorrow. We just have to think about doing it. And we need colleges, and we need hospital and health services, and we need all the other people who are involved in senior levels and leadership in doctors' health, in doctors, in medicine, to enable doctors' health to talk about those pathways to care and for it not to be stigmatised. So the stigma has to be removed from the conversations around doctors' health. It's not all about impairment, it's not all about mental health, it's about...
So when looking at designing solutions for individuals, I think we need to step back and look at having a really multifaceted approach. What we know in designing wellbeing programs is that there's not one solution that's going to work for everyone, that different doctors will respond to different interventions. And we need to think both in the preventative spectrum as well as how we assist doctors when they do develop any physical or mental health impairments. So when drilling down to the solution base, it's nice to think about how we support the individual as well as how we look at then cultural and systemic change. The easiest place to start if you're wanting to start with a wellbeing sort of initiative is to look at the individual support and to try and take a preventative mindset on this. Examples of this would be the BPT-OK program, which has now been rebranded as the MD-OK program. And essentially what that does is says to the trainee that we value your physical and psychological well-being, and we're going to provide organisational support, skills and training for you to try and address this. And just by doing that, that's actually an incredibly powerful thing to do for the trainees. So MD-OK provides opportunities to address some of the drivers of poor health and well-being, which is opportunities, I guess, to exercise, to debrief, to participate in stress relaxation activities, to know what 10 different forms of that are, and to have opportunities to actually practice that and get good at it when you're well, so that when you're not well, you have an armory of things to go to. We know that no one solution, is going to work, and that any solution we try will work for about 5 to 10% of people. So if you're going to implement a wellbeing program, the other thing to think about is putting a multifaceted approach in, because everyone's going to respond to slightly different things going forward. There are some really simple solutions that you can do in the organisational approach. So one of the things that we're doing this year is to look at the fact that doctors often don't have lunch. And when we tried to look at why that is and what the barriers are, we're seeing that they were often interrupted, that they felt that they didn't have any time, and there was certainly a culture of not wanting to leave the wards because they felt guilty about their work having to be done by someone else. So we've introduced a pilot of a protected lunch break trial, which essentially says from 12 to 1 o'clock, the nursing staff are not to page junior doctors unless there's a medical emergency. It also requires the senior staff not to ward round during that time, and the ward clerks and the medical registrars to check in on each other and their junior staff and ask whether they've had their lunch. It's a really simple, low-cost strategy, and the other huge benefit is that patients get to eat their lunch uninterrupted as well, because we know nutrition is a big problem for patients during their stay. So junior doctors win. In terms of thinking about burnout in doctors across Australia and New Zealand, one thing not to forget, and I think has been a real silent part of the conversation today, is that our senior medical staff are also suffering from burnout. They are being asked to look after increasing volumes of patients that at the end of the day they are primarily responsible for, as well as the training needs of junior staff who are burnt out. and then looking for them for support with a skill set that the senior doctors haven't necessarily been trained with. And so we're asking them to do a job role, which is incredibly difficult anyway, and they're already burnt out. And so I think actually to address junior doctor wellbeing, we need to step back and look at our senior doctor workforce and what the factors are that are driving high rates of burnout in our consultant staff. And that's something we should focus on this year.